I guess some of you would know me. I'm Sanjay Mehrotra. I'm a faculty at Northwestern University in the School of Engineering, Industrial Engineering and Management Science. I do healthcare research. But here today, I'm privileged to introduce Stefan Scholtes. And Stefan, we were just chatting earlier today, told me that his career started as a mathematician. Mine too, similarly, as an optimization person. At some point, we drift in the direction of doing healthcare research. So did, many others. So with that, just a little bit more about Stefan. He is a professor at University of Cambridge in School of Business, and he leads the management science healthcare paper submission decisions.
Together with Carrie Chan.
Together with Carrie Chan. And Carrie Chan has been one of our previous speakers. So this is how we're trying to get all the really, if you like, either leaders, decision makers, everybody involved as part of this webinar series. And that is our intention, to keep it really high profile. And then, by the way, I should say this, this will be the last for this year. We will typically be skipping both November and December webinars, just because fourth week of the month and people do get busy because of holidays. This year Informs, there was some conflicts. So depending on Informs dates, we'll either do 9 or 10. And as you can imagine, if you go to the website, which I think everybody should be who's attending today, you can see that these talks are very high profile. And they, by the way, if you don't know this already, they are being recorded, and the recordings are available through the links that get posted on the HAS webinar website. So without much ado, I hope you will be able to see those things. You independently leverage them if you'd like. But Stefan, this was you too, right? Let's see if we can promote this thing across the globe. You are our second international speaker in this, and so I really appreciate you actually taking like late hour time on your side, I guess, to spend the, to educate us. Please go ahead.
Thank you very much. Thank you very much, Sanjay. It's a great pleasure to be with you all, and also thank you very much to the group, the team that set up the seminar series. I think it's a wonderful series, and I'm privileged to have the opportunity to talk to everybody here. I thought about doing something slightly different to a normal seminar presentation. Normally you present a paper. I'll have mixed a paper presentation with a sort of a PhD level course, or one session of the course that I give on causal inference. And I will take a very different slant to what you'd normally get when you talk about causal inference, like instrumental variables and difference and so on. And I hope that is of interest to you. And I'd like, because I get a lot of papers, obviously, I do a lot, my main work is on empirical healthcare operations. So most of them, or many of the empirical papers in management science come my way. And so this is to some extent also a consolidation of some of the experience in the editorial process. But before we start, let me just say what I think about healthcare operations, what it's about. So the objective is obvious. We want to improve quality, access, patient experience, and reduce costs of healthcare services. That's a very, very important part of a very, very important problem in society. And there's two ways you can look at it. One is a macro level way, which I see as sort of a design question. How would you best design healthcare processes? How should you design the organizations that house these processes? Sometimes there's multiple organizations involved. And overall, how do you design an entire healthcare system? There's a lot of work in our community on this, starting with queuing systems in emergency departments, in intensive care units, and going into focused factory discussions and what should be done in a comprehensive hospital, what should be done in a specialized clinic, and so on. Wonderful work. This work is mainly modeling based. And I think it's complemented with what I call micro level work in healthcare operations. Micro level work is trying to understand what affects clinical decisions in the field. What are the modifiable, the factors, the organizational factors that managers or policymakers can modify that have an effect on clinical decisions, on the thousands and thousands of clinical decisions done every day? And what is the knock-on effect of these modifiable organizational factors through the clinical decisions on outcomes, on costs, and so on? So this is really sort of working very granularly in the organizational process of making clinical decisions, where the focal point is the patient-clinician nexus, this decision making. And this work is heavily empirical, typically, in our field. So that's the sort of two aspects to healthcare operations. But the theme today is, how can I make a case that a correlation that I find between a modifiable factor and an outcome X and an outcome Y is actually is causal. So let me carry on with that. So what is causality? I have a very, there are philosophers who go on about what causality is. I don't know much about philosophy. I have a very pragmatic way of looking at it. X has to be correlated with Y, otherwise there's no causality. X should precede Y to avoid reverse causality. And then there should be no unobserved variable that is correlated with X and Y that it can explain the correlation. That's the important part. So there could be alternative explanations to causality between X and Y, mainly through omitted variable or selection biases or things like that. And they have to be ruled out. And when all of these alternative explanations are ruled out, I'm sure that I have causality. That's what's left over. So that's how I look at dealing with causality. So we all know, of course, there are plenty of, or there are not plenty, but there's a handful of approaches that econometricians take to deal with the causality problem in a sort of a more econometric way, and they call it dealing with endogeneity. And one of them is instrumental variables. So how do they work? Just have a quick look. So essentially, you have an outcome Y that you're interested in, and you find that it's got a correlation with X. So the estimated beta is not zero, at least, or statistically significant. And you also have an error term E. But this X could, of course, be confounded by other variables that also affect Y. So we don't know whether beta is causal. So now you set up an explanation of X. You find another variable Z that affects X, also with an error term. And you use that variable to clean the beta up and make it a causal beta. How does that work? So here, suppose you have you have a variable Z, and that affects Y. And you know that with every increase of Z, Y increases by 2 units. That's not to do with X yet. But now you know the only way that Z can affect Y is through X. There's no other way. And every unit increase in Z increases X by 4 units. If you know that the only way Z can affect Y is through X, then X has to be causal. Right? Because all you do with changing Z is you change X. You don't change anything else. Everything else remains the same. So the only way this can work is if X is causal. So the first thing you have is X has a causal effect, but how big is it? Well, Z changes Y by 2, it changes Z by 4, so the X must halve the 4 to get back to the 2. That's an instrumental variable. So here's the estimate is basically the beta you get from aggression of Z of Y and the beta you get from aggression of Z on X in a very simple form. So it's a wonderful way. In the randomized controlled trial, you have Z is a coin flip, right? A coin flip decides on a treatment. You get treated or you don't get treated. It affects Y, but it can only affect Y through the treatment. But Z doesn't have to be a coin flip. It could be another variable, an exogenous variable. So what you need for all of this to work is that Z has to predict X. So the correlation between Z and X is not zero. You need what people call the exclusion restriction. Z is associated with Y, this 2 here, only through X. There's no other way Z can affect Y in another form. And also something that people often forget is a homogeneous response assumption. You have to make sure that every subject in your analysis, the exposure to the treatment X is affected by Z. There can't be a subset of some of the data that is not affected by Z. So you could still have a strong correlation if half of your data is strongly affected by Z and the other half is not. You'd have a strong correlation. That would not be an instrumental variable. Because you only clean up the relationship between X and Y for the half of your data that is actually affected by Z. So you have to make sure that Z does affect every single observation, or has a chance to affect every single observation. That's often it's not as often looked at as a criterion, but it's very, very important. Okay, so that's instrumental variables. What did people do before instrumental variables? Here's a very famous British statistician or biostatistician, Sir Austin Bradford Hill, the president of the Royal Society in the 1950s. And he wrote this very influential paper called The Environment and Disease Association or Causation, where he sort of came up with a number of reasons that make a case for causation stronger. These are not reasons that give you an absolute case for causation, like a randomized controlled trial, but they are arguments that you can put forward to say, actually, I think we have a causation. So they're called the Bradford Hill criteria. So the first one is my effect size large enough? If you have only a very small effect size, it is much easier for an omitted variable to eradicate it. So if you have a large effect size, you have more leeway to get it shaved away by some omitted variables. If you only have a small effect size, he says, I'm a believer of that. I want to see a large, meaningful effect size before I start going into endogeneity questions. The second point is consistency across studies. So if you have multiple studies from different contexts, let's say a US study, an Indian study, and a UK study, all showing similar types of associations between X and Y, it becomes more plausible that you have causality. Specificity is very important. So if you make a case for all patients that visit a primary care physician, that's a much more difficult causal case to make than if you say it's only for dialysis patients. Much more specific patient group where you can make a much more specific claim. Temporality is clear. We've already talked about that. X should happen before Y. There should be clear. And if there's an expected delay, you should see that expected delay in the data. Those response relationships give more, and you should see a larger effect. For example, Bradford Hill was very instrumental in proving causality between smoking and lung cancer. He wrote a series of papers on that. And so if you smoke, you're a normal smoker, you have a 10-fold increase in your chance of dying of lung cancer. That's a very big effect. So the large effect size is a tick. But if you're a heavy smoker, you have a 50-fold chance. That's this dose-response relationship. If you can show that, that gives you more of a feel. This is actually a causal piece. There should be a plausible mechanism. If you have for the smoking case, if you have a chemical mechanism in the cell that allows you to make an argument, that makes the causality so much stronger. There should be coherence between observational and laboratory. If you can get that, you can get coherence between your observational study and laboratory studies. That helps. For example, you might have laboratory studies in animals. And if you see cancer evolves in animals when they're exposed to smoke, That's not the same as in humans, and in humans you can't make that study. But there's coherence between lab studies and your observational study. If you can do an experiment, obviously, if you have some sort of way of doing that. And also he says it's useful to have sort of analogies or similarities between observed associations and between your observed association and some other associations. So it's a list of criteria that he puts forward. It's nothing to do with instrumental variables. It's just thinking about what would me make believe more that I have got a causal correlation. Another way, by the way, there is a critical assessment of these criteria by John Ioannidis, who some of you will know as a star statistician at Stanford. So it's not completely, this is not universally accepted, but it's been something that's been very instrumental in the medical field. So I like that to a detective mindset for causal inference. The question is, did X kill Y? Right, that's the cause. X was the cause of Y's death. Did X kill Y? And think about an argument that a detective might have with a prosecutor to convince the prosecutor that a case against X should go to court. That's exactly the same context that we have as authors of papers when we argue with the review panel that a causal claim about X should be published. We should put ourselves much more in that mindset of the prosecutor. So what do I want? What does the prosecutor, first question the prosecutor asks, has X got an alibi? In our context, an alibi is zero correlation, right? If there's no correlation, there's no reason to make a causal claim. Does X have an alibi? Did the suspect X actually have the opportunity? So for us is there evidence for a strong, practically meaningful association? Second question is, why? What's the motive? Is there a motive? If there's a motive, it's much easier to make the case. So are there good a priori reasons for a causal effect without the data? Without the data. Third question is, what's the murder weapon? Right? So how did it happen? Did the suspect have the means to do the crime? And for us, that means we need to think about, can we put our hands on a mechanism? How does it work? How does that causal effect, how is that actually achieved? And is there evidence for that mechanism in the data? So it's not just make an instrumental variable claim about a causal effect. Can I go into the data and find evidence for a mechanism that makes X cause Y? And then the fourth piece, and the most difficult piece, is X the only credible suspect, or are there alternative explanations? Could there be others who might have also have no alibi, a good motive, and the means to kill Y? That's called an alternative explanation. So what you have to do is you have to spell out all the alternative explanations, and then you have to use data to refute them. And what you're then left with is the only option then is that X is causal. Right. So it's a very different path through an empirical paper. And I'm going to talk you through a paper that I've recently published with a PhD student and some other people in management science. That's about the opioid epidemic. And I'm going to talk you through this with the mindset of the detective, because that's the mindset we had when we wrote the paper. Structure of my talk is, what's the societal problem? Who's trying to solve it, and how are they doing it at the moment? Which decisions does the paper aim to inform? What's the main new finding? Do I believe it? That's what we're going to talk about a bit more. Do I believe this main new finding? And what are the recommendations for the decision maker? So let's see. Let's go. So the problem that we address is the opioid crisis. I don't think in this audience I need to go into this, This is a striking graph on opioid death rates per 100,000 population per year in the US. It's still going up. It's particularly going up amongst opioids that are very, very powerful. So you have fentanyl, that's sort of a morphine type opioid, but it's 50 times more powerful. So there are these opioids are really killing people. People become addicted to them. They get killed. And in fact, not just young people, old people as well. And here are some numbers. 2018, 47,000 fatal opioid overdoses, 2 million patients diagnosed with opioid use disorder. And the economic costs of the opioid use disorders have been estimated by the CDC as over $450 billion US. They're very, very complex patients, very difficult to handle, and very expensive. So that's the context, that's the problem. Whose problem is it? Well, it's a lot of people's problem. It's a politician's problem, it's the CDC's problem, it's the regulator's problem, it's the hospital's problem. We are focusing on primary care. And the reason for that is that a lot of opioid prescriptions, in particular initial prescriptions, are done in primary care. So primary care patients often put patients on an opioid journey. And we're going to look into that journey. So 215 million in 2016, 215 million opioid prescriptions, a staggering figure, 66 prescriptions per 100 people in the US. That's come down now recently, but still it's still a very large number. And almost half of them are actually initiated in primary care. So we're going to look at opioid prescriptions, first time of an opioid prescription in primary care. That's the context. Can we do something there? How is the medical community actually trying to solve that problem? It's trying to solve their problems with guidelines and with educational physics. And that makes perfect sense. So here you have a couple of guidelines. The point is that the medical field basically focus on the end of the opioid journey, when patients already are addicted. How do you manage patients who are addicted to opioids? We do exactly the opposite. We look at the very start of the opioid journey, and there's very little there in the medical literature that helps us sort of maybe try and do something early on, prevent them from becoming addicted. So what's the decision that the paper informs? I always, when I've seen empirical paper, I always want to exactly know what is the decision that you want to inform. If there's no decision that the paper informs, the paper can still be interesting, but it's unlikely to be useful. There's got to be a real decision. And here's the decision. So the data we look at primary care practice appointments with so-called opioid naive patients. So these are patients that haven't had an opioid prescription for at least 6 months. They come to their primary care physician. They have an appointment with a doctor, and the doctor might, they choose the treatment plan. And if that treatment plan doesn't include opioids, they go back into the sample. They're not of interest to us. The folks that are of interest to us are the patients that fill an opioid prescription for the first time. So they're opioid naive, and now they had a PCP appointment, and they fill their first opioid prescription. Now they're of interest to us. But many of them actually only fill one prescription because they had an acute problem. They only fill one prescription, and then they don't do opioids afterwards. We are looking at those that carry on doing opioids, and we identify that with a follow-up appointment within 30 days. And the reason for that follow-up appointment should be roughly the same. I can explain what that means. Should be the same as the reason for the original appointment. So it's a pain-related appointment. And what happens with this follow-up appointment? Well, the question is, one question that you might ask yourself, who should do the follow-up appointment? More specifically, should it be done by the same doctor, or should it be done by a different doctor? And what's the consequence for long-term opioid use? So think this through. How would that work? So you have a follow-up appointment, you have an initial appointment, you take opioids as a patient. You need a follow-up appointment within 30 days, relatively close by. why would it matter whether you have the follow-up appointment with the same doctor or with another doctor? We'll come back to that question later on. What we mean by long-term opioid use is we follow the patient over a year after basically after the follow-up appointment. And if they had more than 180 days prescribed of opioids in that 1 year, we call them a long-term opioid user. That is really a lot of opioid prescriptions that you have. We've also got another measure for it, but that's I'll leave that out. It's in the paper. Okay, so that's the decision. This is the decision. It's a simple appointment decision. What's the data? There's a lovely data set from the US. It's a data set of medical and pharmaceutical claims, about 3.5 million beneficiaries over 6 years. And we only look at patients who have at least 18 months continuous eligibility in that data set. So here's the pharmaceutical claims. You have the patient ID, you have the prescriber ID, you have the fill date, you know what the drug is, you know what quantity was prescribed and was dispensed, and so on. And we match that up with medical claims that tell you, where when the appointment happened, where the appointment happened, what the diagnosis was, what the reason was for the patient to come into the practice, and so on. So we mix all this up, take all this data, and here is a first indication. So we have, after all this cleaning up, we have about 11,340. We have 11,340 patients in the sample, of which 72% had a follow-up with the same doctor and 28% with a different doctor. Look at the difference in long-term opioid use rates. That's almost double, right? 11.5%, 6.2%. Okay, that's what I call a meaningful correlation, right? That's big. That's big. So first question, I'm saying, so my X here is, should I have schedule the follow-up appointment after an initial opioid prescription? Should I schedule the follow-up appointment with a different clinician? Have a second pair of eyes, someone else? Or should I leave it with the same clinician? And there is a very strong effect, very strong association. So the odds ratio is 0.51, and see the confidence interval here. So the suspect X did have the opportunity, but that's just the first step. So let's move on. Next question is this small or big? Does this matter? So let's have a look at the 1.8 million patients that are eligible in our data in 2017. Of them, 0.15% were included in our analysis. So they are the ones that we really look at. Of those, 71% saw the same doctor. Of those, 10.3% were long-term opioid users. Now we've boiled it down to 200 patients. But we could save half of them if they had seen a follow-up, if they had seen a different doctor for follow-up. So we could have saved 100 patients. Now, if you extrapolate that to the United States, you have 330 million as size of the population. You get 17,000 annual opioid users saved or avoided. And if you take the opioid disorder cost estimates that we had before, that amounts to $4 billion US. Now, don't get me wrong, I'm not claiming that that's the case. All I want to make is, I want to understand, if there were a causal relationship with that odds ratio of 50%, how important would that be? And I think it would be very important, right? So now I've made the case, if it's worth digging further. I don't have a petty crime here. I have something that's really important. We haven't established causality yet, of course. Is this obvious? It's interesting. So most clinicians who we asked said, actually, I believe that the effects to go in that direction. Here's one quote of a clinician. It says, "It is not surprising to me that clinicians want to continue an opioid-based treatment plan if they were the initial prescriber. follow-up by another doctor minimizes the friction the initial prescriber would have faced when refusing to refill an opioid prescription that originated from it. So if the patient comes in for the follow-up, it's much harder for the doctor who has given the initial prescription to say no than for another doctor. And so what is interesting here is, I think, is it's not so surprising that we have this kind of effect. What is surprising is how big the effect is. That's the argument for the paper. It's not that there is an effect, I can believe that, but that is a really big effect. So why does that happen? Why would the follow-up, so now I'm asking about a priori, before the data, sort of theoretical, plausible arguments for this effect that if the patient sees a different doctor, the chance of becoming an long-term opioid user is lower. And I think there are two arguments. The first is there's an information advantage. So the second doctor might be able to, they might know better alternatives to the opioids, or they might be able to, they're taking the history to get more information from the patient than the original doctor gets, and then maybe fit a different treatment regime. And the third one that I think, the second one that I think is more convincing is this notion of anchoring. If I have made a decision in my initial consultation as a doctor, it's much harder than to say that wasn't the right decision, or we need to now move away. If the patient's situation hasn't changed, right, they still have pain, am I now going to say, nah, that wasn't a good idea? Even if it's much harder. And then that might also have confirmation bias, in the sense of that I think that should be the decision. I'm now asking for information that confirms my decision. So these are sort of sensible arguments that one can put forward. And that would go into the hypothesis section. So if you develop a hypothesis, we typically develop hypothesis section. I'm not a big fan of that name, hypothesis section. But I think what we do need is, we need to have a credible explanation a priori why there should be a causal effect. Next question is, what's the murder weapon, right? How does the second the follow-up patient, the follow-up doctor who's not your initial prescriber, how does that follow-up doctor reduce long-term opioid usage? And the only thing that comes to mind is they reduce short-term opioid usage, right? So the fill rate, what we would expect is that the alternate clinician is better able to reduce the use of opioids immediately after the follow-up appointment. And that's something that we can check with the data, right? So we say, okay, let's define a new binary variable V that codes, does the patient fill an opioid prescription within 14 days of the follow-up appointment, yes or no? And X is the follow-up done by another clinician. And what the data tells us is X does in fact reduce V. So follow-up, doing the follow-up appointment with a different clinician reduces your chance of using opioids immediately after the follow-up appointment. And that hugely reduces your chance of becoming a long-term opioid user. So same thing, right? I have no alibi, strong, where are we? I have no alibi, so strong correlation. I have some arguments why, and I've also now got a data confirmed mechanism how. Now we go on to the third point, which is X the only credible suspect, or are there alternative explanations? And that's where most of the econometric work lies. So let's move on to that. So alternative explanations are clear, I hope, to most of you. So we have a correlation between follow-up by a different clinician and long-term opioid usage. The question is there, and that should be negative, so it's follow-up by different clinician reduces long-term opioid usage. If there's another variable out there that's correlated with the follow-up, negatively correlate with the follow-up, but positively correlate with long-term opioid use, then that can explain the minus side, or the other way around. If that's positively associated with follow-up, negatively associated with long-term opioid use, that explains the minus. So what are the alternative explanations? What could potentially correlate X with Y? And there are lots of things. And for some of them we can control, and for others we can't control. What I often see in papers, and what I don't like, is we control for X, Y, Z, and so on. So you get a whole long list of variables. It doesn't tell me why you control for them. You got to tell the readers what the alternative explanation is that you rule out by controlling for these variables. So health condition of the patient, what we can control for is that can of course affect the follow-up, whether the follow-up is by a different clinician. So for example, if you have something that is outside of the specialty of a traditional general, outside the general medical field, and you have a specialist for that condition in the practice, then the follow-up is likely to be done by that specialist. Right? And that could also affect long-term opioid use. So we've got a number of things that we can control for. We've got the ICD for the reason for the appointment, got disability status and chronic diseases that we can control for. We've got demographic information that we control for. I go quickly through this, but there are always good reasons why we need that in terms of alternative explanations. Because I want to get to things that we can't control for so well. One of them is acuity and severity of the patient's pain. If I have an acute pain problem, I'm calling up the primary care practice. Suppose I have a regular family doctor, Dr. Smith. Dr. Smith is not available today. I heard so much, I need to go and see a doctor, whoever it is. And I go to Dr. Jones. But next time I go in, I go to Dr. Smith again, because he's my regular doctor. And Dr. Smith realizes, oh, Dr. Jones has given you opioids. I don't think that's a good idea, because he's my regular doctor. I trust him. So I do what Dr. Smith says, and I don't continue to use opioids. So it could well be that the acuity that has driven me to Dr. Jones instead of Dr. Smith is actually at stake, is actually affecting or causing that correlation. So what have we got? We have got the dose, we've got the drug type, which is important, but also we've got the dosage of the first opioid prescription. So if you have acute pain, you can't wait. It's likely that it's also severe. It's not only coming fast, but it's also really hard pain. And therefore the dosage that you get is likely to be high. So it's sort of a bit of an indicator, but I'm not terribly happy with that as a control, because acuity can be, there's a lot of other things that doesn't capture. Okay, and the last one is I'll have to move the thing up and down here. The last one, that's better. Just a sec. Last one is patient choice. So some patients want to be seen by a specific doctor, and they will never do a follow-up with a different clinician. So we have no information about these patients, whether patients are more likely to be or to only want a specific doctor. We don't know that. So there are a number of alternative explanations that I think we can control for, but there are also some that we can't. Let's go first to the controlled results. The unadjusted result was an odds ratio of 0.5, almost a 50% reduction of risk. If we adjust, that changes. It changes to almost 0.7, so it goes up significantly, and the risk reduction is much lower now. I'm glad that it's lower, because I do not believe that it can have a 50% effect. I want it to be much closer to a 20% effect. So I'm seeing that happening here. The confidence interval is sort of, it's reasonably wide. What is very interesting is when you look at when you let the controls fly in one after another. So what happens to the odds ratio? So if we have no control, as before, it's an unadjusted odds ratio of 0.51. The moment we just put in the initial prescription dose, whether it was a high dose or a low dose, it jumps to 0.66. So that shows you that acuity argument is really an important argument, because it reduces the effect significantly. And the dosage sort of picks up, to some extent, acuity. It also picks up severity, but that's a different story. And once you add patient characteristics, patient conditions, or all the other variables, then not much happens to the odds ratio. So the big effect is really, let's make sure that we have the severity and acuity of the onset of pain captured. I'm gonna go through this a little faster. Dose response. So Bradford Hill says, if you increase the dose, you should get a more of a response, or reduce the dose, you should get less of a response. How can we get those into this analysis? So you can't give someone half a follow-up by a different clinician. So what you can say is, let's look at allowing follow-ups not just after 30 days, but also after 60 days. So now the gap between the initial appointment and the follow-up appointment is larger. And therefore the response shouldn't be quite as strong. And then we go to 90 days, and again, the response shouldn't be quite as strong. Do we see that? Do we see a dose-response relationship of that kind? And here's the graph for it. Yes, we do. So if we only look at follow-ups within the first 30 days, the effect is the strongest. And if we then move to allowing 60 days, allowing up to 90 days, allowing up to 120 days, the effect disappears. And if we allow follow-ups to be long enough apart, then there's no effect. So it is not conclusive, but it's another piece in the puzzle of making an argument for causality. Okay, so the still insufficiently addressed alternative explanation, I've already said, is patients with acute pain onset are less likely to wait for access to their regular doctor. When they then see their regular doctor for follow-up, that regular doctor corrects the mistake of the colleague and reduces the chance of the patient becoming long-term opioid user. Okay, we need to do an IV regression. So what is an instrument? We have two instruments. I'm only going into one here. One is, we look at the initial prescriber, and we ask how many of their patients in our data are actually followed up by someone else, and how many are followed up by themselves. So it's the follow-up rate over the past year prior to the initial prescription of the prescribing physician. And we're saying, well, if someone tends to follow up with their own patients, with their other patients a lot, they're likely to also follow up. They're more likely to also follow up with their current patient. We're also saying that the only way that Z can affect long-term opioid usage of the current patient is through its effect on X. The IV brings the effect down to 0.46. For my taste, that's too much. It's the confidence interval is wider. That's typical for IV regressions, but I don't believe that there's a 50% reduction in risk. So the IV, wrong with it. There are these untestable assumptions. So homogeneous response. Well, some patients just insist on seeing their own doctor. So maybe that Z doesn't have the same sort of, doesn't have an effect on a subset of the patients. And that matters. And the exclusion restriction, you can start arguing for ages. So we say in the paper, we have no reason to expect that the switching rate of these other patients should have a direct impact on long-term opioid usage of the focal patients. But the problem is, yeah, you can say that, but there are often omitted variables in that relationship between the instrument and the outcome. And so, for example, you could have low-income areas. They have fewer doctors. And therefore, because they have fewer doctors, you have less of a chance of switching to a doctor. You're more likely to stay with the doctor. But they could also have low-income areas. They could also have a higher long-term opioid usage. So this is the typical sort of gray area of trying to justify an instrument. Every instrument can be attacked, and these assumptions are untestable. So we have a problem. One way we've tried to address the problem is through an estimation method called minimum bias estimation. So what you do here is you use propensity score matching. So a propensity score is the chance that a patient gets treated. And you estimate that chance. And then you match treated and untreated patients that had the same chance or similar chance to being treated. And so if you are at 50%, if you have a 50% chance of being treated or not being treated, then this is almost random. If you have a 20% chance of being treated or not treated, you are far away from randomness. So what we have here is we see this is basically looking at the propensity score ranges that we allow. So the smaller the range of propensity scores you have, the smaller your sample size, of course, becomes. And so this is the most randomly, in quotes, pseudo-randomly chosen sample. That's it's between 0.33 and 0.67 as a propensity score. And then we use weaker samples where the controlling isn't quite as good. And as the controlling gets worse, our effect also gets worse. And that again is something like a dose-response relationship, but it's a different dose-response relationship in the sense of the matching quality of the treatment and the control group. And the worse the matching quality becomes, the worse the effect becomes. That's again, for me, that sort of makes sense. And there's a whole estimation method around that I don't have time to go into. Still, patient acuity, right? We still haven't addressed that problem. So let's check it directly. So what was the argument? The argument was that when I have an acute pain, I probably don't have time to see my regular doctor. I just go to some doctor. But then I see my regular doctor afterwards, and the regular doctor corrects the mistake. So let's identify regular doctors. We did that in the data. It said, define the patient's regular doctor at the time of prescription by looking at the providers who saw this patient most frequently over the past 2 years prior to the index appointment. So, that's we call those we call this provider their regular provider. And if there was a tie, if there was sort of two providers with the same frequency, then we would take the provider that saw the patient most recently. So now we are not looking at concordance. We call concordance, you've seen the same for the same clinician for the follow-up and the initial prescription. And this is discordance. Discordance is when there were different doctors. But now we have 3 different types of discordance. One is you first see your regular and then an alternative doctor. Then, and we've got about 1,000 of those. You then see the alternative is first see an alternative doctor, then your regular doctor. So this is the one where we say, okay, the regular doctor corrects the mistake of the alternative doctor. And the third is you see one alternative and then you see another alternative doctor. Okay, let's see what the results are. So what we see here is, first of all, for all this is relative to seeing the same doctor. So for all of those pathways, we see an effect. We do, in fact, see a stronger effect when you've seen an alternative provider and then followed by a regular doctor. So that's the strongest effect. So that gives some credibility to the idea, yeah, there is something there in this alternative explanation. But the alternative pathway, you see the regular provider and then an alternative provider, still has a strong effect. In fact, that's an effect size that I can much more easily live with than this, in terms of talking to clinicians about it. So we're not ruling out any acuity. We're just saying that that this alternative explanation is likely a partial cause. But even if we remove it as an explanation, there is still a strong effect. And this is all, you know, within instrumental models as well as non-instrumental models. So we've done something else for another alternative explanation that I don't have time to go into. So in summary, the weakest point in the paper is lack of information. It's a data problem. It's a lack of information on acuity. So for example, if we had not only had the time when the appointment happened, but also the time when the appointment was requested, we would have been able to just control for acuity, and that would have been wonderful. Unfortunately, we don't have that luxury. So that's a weak point of the paper. But even if we take the most conservative estimate of the, you know, you see your regular doctor first, and then you see an alternate doctor, even if we take that, then that's quite an effect size. And if we take the upper limit of the confidence interval, we still save 1 in 10 long-term opioid users, or approximately $800 million per annum. As savings. So what do we recommend as a follow-up policy for practice? The patient has been prescribed opioids by their regular PCP, schedule a follow-up with another PCP. Because it's still worth doing. The effect here is this. If a patient has been prescribed opioids by someone who is not their PCP, make sure, that's more important, make sure that they're seen by their regular PCP because they corrected. And so this is the conservative estimate that we had. I would say the strength of this evidence is only moderate, because there is still an issue, and we have clarified that in the limitations section of the paper. So if you have something like that, make it clear. Don't try and hide it. We've clarified that in the limitations. And so it's clear that this should be followed up. This was a retrospective study. This should be followed up by a better designed prospective study, where you're trying to really affect whether someone is seen by a different follow-up doctor or the same follow-up doctor. Okay, so this is the summary slide that I'll leave you with. Take a detective mindset when you make a causal claim. Think about these, you know, do I have an alibi? Is there a strong enough practically meaningful association? Do I have a good hypothesis section that lays out a priori, outside the data, arguments why that makes sense, the causality? Do I have a mechanism? Do I have evidence for that mechanism? And then use creatively your data to rule out, first of all, spell out the credible alternatives, and then use creatively your data to rule them out. Don't just say we are worried about endogeneity and let's use an IV. That's it for me today. Thank you very much.
This is a wonderful, wonderful, wonderful talk. I mean, I couldn't have related to it any strongly, because we're dealing with one of these issues as we speak. I'm going to ask you a start-off question, and then we go back with that. So right now, it was the other direction. You're trying to take a detective approach to doing this, inferencing, causality inferencing, Stefan. What if everybody believes that the cause is there, and your interest is in trying to understand the effect size of that cause, and somehow you're not able to do the inferencing in this, like go back to the causality diagram that you created. What do you do?
So I'd say we need several studies. So we're not very good at meta studies. The medical community is extremely good at that. So a single study for them means not much, even if it's really well designed. They'll wait for. We are terrible at that. Once in particular in the leading journals, right? It's very. It's if you're the second to show something, it's very hard to get your paper in.
Yeah.
So and I think we have to find a way to incentivize colleagues to do follow-up studies in different contexts with different types of data, so that we build around an important decision, so that we build a repository of evidence, and then do a sort of a meta study of some sort, and then we come closer to that, right? So then we at least understand what the range of confidence intervals are.
But prospective studies are so expensive to conduct, particularly when you're trying to do it, because ultimately, if you're concluding things that it's prospective study that would eventually kind of, hopefully done properly, would provide the goal.
Isn't that the point? You have to provide retrospective evidence, sufficiently convincing retrospective evidence to convince people to do a prospective study, because they are so expensive. And that would then be the real thing. So designing a prospective study for this thing that we've just been thinking about is not easy.
It's not easy.
It's not easy.
And I guess the problem there is that because clinical practice environments are so different across different institutions, and at least we can only draw aggregate inferencing even with that, right? So it's just this prospective studies. I mean, even for something like this, if you enroll patients, it's going to be huge number of patients coming in, and then when it's trying to kind of do the gold standard. So I mean, I'm trying to make a case where some of these decisions have to be made through just secondary data analysis.
So I thought it's interesting. I don't necessarily think that you need to recruit patients. You need to recruit practices.
Okay.
And many. So that's the problem. And
that is the problem too.
Exactly. But you have to also deal with the fact that patients have a choice. You can't just say you are going to have a follow-up appointment with a different doctor. No, you want the same doctor.
You have to do something in the IT to do that, right?
Exactly.
Yes. So anyway, sorry, I'm speaking too much.
Incentivize the patients.
Absolutely. I think I'm seeing the full football field here, but
exactly.
I don't want to hog the time, because we only got a few minutes. Maybe we might run a little bit longer. I'm not sure when Informs cuts us off, but I am at least should be opening things for questions from the listeners.
I have a question, actually.
Okay, Sid, why don't you go ahead?
So my question is about the thought process, Stefan. So how did you come up with X? Like, looking at this problem, the opioid problem, like, you look beyond the patient characteristics, the socioeconomic status, the family history, everything, and you looked at the follow-up doctor. So can you elaborate more on how?
I can tell you exactly how it happened. So I work very closely with the primary care practice. I'm chair of the board. It's a practice with 30 doctors and 45,000 patients. And I'm patient chair because I'm also a patient of the practice. And so we have a patient participation group, and we were sitting in the patient participation group, and everybody was going on about continuity of care being so important. And it's hugely important, right? And then one of the doctors said, wait a minute, sometimes I want a second opinion. And I thought, that's interesting. And he gave this example of, opioid use. He said, really, you need it. And that's it. So that's how it came up. I mean, I didn't do anything about it. It just someone else suggested it.
Nice.
Such an important piece of work. I couldn't emphasize more, because there's so much, even in the publishing side of things. People get publish things in the medical literature where studies are not well conducted. I mean, even secondary data analysis is not well conducted, and people start drawing inferences from there, and sometimes consume what's in the literature. And
exactly, and it's we also have to be, I think, more honest about the limitations. We as authors know the limitations best. But the refereeing process drives us nuts because we can't spell them out because
I mean, it's probably true even for our management science papers, right? I mean, we, not to put the ball back in your
I'm not saying
court.
anything against the refereeing, but I mean, the refereeing process is hugely important because they do play that role.
No, I'm not discounting that, but sometimes referees got this limited mindset, and just to go over the hump of what they know and what the authors know, it's a sort of a delta that you can never bridge. And they come back 2 reports, and they're both negative. The editor says, you're over with. And this is where a lot of the research struggles, particularly if it's done well, and it's a hard decision making there as well. I'm not blaming. I mean, you're a decision maker in some of these things, and I'm not blaming. I'm sorry. I'm bringing up that issue because I know a lot of people try to do good work.
Yeah.
And we just sort of, there's a lot of their good work gets killed in the refereeing process.
I think we got a question from the audience.
There is a question. I mean, brought up the refereeing thing.
Tolga, good to see you.
Yeah, I think Tolga raised his hand, and there's another question in chat as well, in the quick Q&A margin. So should we allow him to talk?
Yeah, please go ahead.
Yes.
All right, excellent. Thanks, Stefan. I'm not going to try to turn on my video. I don't even know how to do it. Anyway, a great talk. I guess I have a more general question, I guess, and I suppose you can use the example of the paper that you presented to demonstrate some of the topics. Obviously, I don't work in this field, so I'm still trying to understand the big picture here. So when do you stop asking questions for alternative explanations, basically? When do you, as a scientist, say, look, enough is enough. I think I have enough evidence that my explanation is the real mechanism that cannot be something else?
When you really think that there isn't another alternative explanation that you have at least tried to address. And so there is an intuition, a context aspect to it. Right, so you can come up with alternative explanations that might be the case, but they're unlikely to actually rock the boat much. So there might be some a small omitted variable there that you don't have in. If you have something like this, and you go to the clinicians, and the clinicians as I said, they believe that there is an effect there. They would not buy a 50% effect. And so there's got to be an alternative explanation, and that's this acuity piece. When you are in a range where the clinician, with your effect, where the clinicians say, that could be credible, that's one aspect where I'd say that's a good point. I always ask the clinician, what do you think is the reason for the correlation? That's the one thing every clinician understands. Correlation is not causation. And they're very creative in coming up with reasons why. And you have to have an argument against all of those all of those alternative explanations that the practitioners bring up. So one thing in the refereeing process that we don't do well, in fact, in this paper, there was a medical referee involved. That was fantastic. We do not involve enough practitioners in our review processes. There should be in every paper, in the ideal world, should be one practitioner who understands the academic game, who's really interested in academia, but who's actually a practitioner, to be involved in writing a high-level review. That'd be good.
Cannot agree more.
Does that make sense?
Medical decision making has that mechanism, right? I mean, that's one journal that actually goes to the practitioners plus the, but again, it's not management science, obviously.
Yeah, and you need a panel of practitioner referees. So we'd have to build a panel.
Exactly, and given how mathematical some of our papers become, I mean,
Yeah.
Well, I guess we've way past time. Still open to questions if there are any more.
I think there's one in the Q&A platform.
One. For some reason, I'm not seeing it. Okay, here. Well, should I read it or? So Sanjana Mendu, so she's asked, she called to comment. So thank you for the very informative discussion, detective approach. Do you have any advice on how to reconcile heterogeneous measurement of outcomes of interest, quote unquote, the suspect? It would be great to create the comprehensive base of evidence. And I'm sure you can read it too, Stefan.
I can't read it, so
Oh, you cannot. So let me read out. Okay. So, but
when I can comment on heterogeneity. That's a
sure.
very important point.
Okay, please go ahead.
Yeah. So heterogeneity. I mean, what we don't do enough, I think, is subsample analysis.
Mm-hmm.
We tend to try and do a lot of moderation effects and so on. If you have heterogeneity issues, do subsample analysis. Today, we often have quite a lot of data, so we have the luxury of being able to do it. So I think if you find a correlation across heterogeneous groups, that is in a subsample, not just in a controlled regression, in a subsample.
Mm-hmm.
That is very important.
Mm-hmm. Okay, I think that question is answered, but I think as we're continuing reading the comment / question, there was a very great concluding statement which sort of validates exactly what you just said. So something like stress can be operationalized through 100 different mechanisms. And I guess if stress is the point, each one of us takes stress differently too. So just thinking about subsamples and mechanisms, I think it sort of makes the point about heterogeneity.
Yeah, and also a point about measurement.
Mm-hmm.
It's very hard, right?
Very hard.
Self-reported measures, pain, for example, pain scales, very difficult.
Okay, I guess another comment. No, I think it's a great discussion that's happening. So Maria Tostalo, Maria is making the point that wouldn't then heterogeneity be an indication to some alternative explanations too?
Potentially. Yeah, heterogeneity can always be, is always a good argument, at least. So it could be an argument for causality not going in the right direction, but that's less likely. I think it's often an argument that the effect size is wrong. Your estimate of the effect size is wrong. Yep. And it's important to understand for whom does the X variable have which effect.
Mm-hmm.
Right?
Mm-hmm.
Yeah, I think that aligns with the question I wanted to ask is like, I noticed your data, it spans from 2012 to 2018, is that right? Like over several years, right? Yeah. But during these years, there are regulation changes, legislation changes, the PDMP prescription monitoring program set up that might affect the prescribing behaviors, right? So I think you just answered the question. Maybe you can run stratified analysis at a different time frame, see if this effect size holds true qualitatively across the bucket.
I mean, you should of course control for time, which we do, but it's more, okay. I think more powerful if you do stratified, if you do stratified analysis over subsample.
Yes.
Gives me a better feeling because then all the other variables are
right.
different. Right?
Yes.
Yeah.
I guess we're 10 minutes past the time. So maybe we should conclude, and the talk will become available publicly once it gets sort of processed. So I see that about 40 participants are waiting, but maybe about time to conclude. And then, we'll look forward to seeing that, everybody who's still here next year, and hopefully start this webinar series with another bang. Thank you very much.
Thank you all.
Have happy holidays or happy everything between now and Informs and the rest of it, because we won't see everybody, right? So, you take care. Yeah, Stefan, wonderful talk again. Appreciate it.
Bye-bye.
Bye-bye.
Thank you.
Bye-bye.